Hello everybody, my name is Helen Chatterjee. I'm the Programme Director for Mobilising Community Assets to Tackle Health Inequalities, which is a research programme led by UK Research and Innovation. I'm also a Professor of Human and Ecological Health at UCL, and I'm part of the national programme team overseeing the Mobilising programme. I'm really sorry that I can't join you today for your Brilliant Choice Project event. I really hope to be able to get to your next event. But I'm here today just to tell you a little bit more about the Mobilising Community Assets Research Programme. And I'm really looking forward to learning more from you guys about what's going on in the Choice Project. So a little bit of an overview of the Mobilising Community Assets Programme. The aim of the programme is really to understand how best to integrate cultural, natural and other community-based assets within the changing structures of health and social care, with a particular emphasis on thinking about how we can better support the poorest people living in the most deprived areas. We're also really interested in understanding how we can better integrate lived experience into this kind of health systems change, particularly drawing on the lived experiences of people using health and social care services and how these experiences can be better integrated into health systems change. So Mobilising Community Assets is a £30 million research programme, and I've been working with the Arts and Humanities Research Council, which is one of the research councils across UK Research and Innovation, for the past 5 years developing this programme. In the first instance, we were quite small and we were thinking about how best to bring together the knowledge and expertise around community assets and health systems change. And we've developed the programme over the last few years with the support of the other research councils across UKRI. I'm part of the national coordinating team, which is based at University College London, and we work in partnership with the National Centre for Creative Health to deliver the programme. And we've been delivering this programme over the past few years. In the first iterations of the project, we funded 2 phases of research. In phase 1, we funded 12 pilot research projects, which was a total investment of £1.5 million. And in phase 2, we funded 16 consortium building projects, which totaled £4 million spend. And you guys are part of phase 3 of the project, which is 12 large-scale research projects with a total investment of £25 million across 3 years, starting from last year and running until 2027. So we funded 12 projects in this phase, like I say. One of your projects, the Choice Project, you'll see listed here, and we've deliberately selected projects that span the full range of community assets and innovation across the UK, so including the devolved nations and across what we hope are some of the most deprived communities in the country, thinking about how best we can understand learning from those systems where we know there's great work happening, but we know that more innovation is needed to think about how to bring best those innovations to light, in particular to support the communities that need it most. And when we're talking about community assets, we're talking about the full range of community assets and resources, networks and systems within that broad communities ecosystem. So you'll see in these projects a really diverse range of different types of inequalities, different types of health conditions and different geographies that are reflected in the projects that have been invested in. So what's our role? Well, in the national programme team, in partnership with the National Centre for Creative Health, our role is to support projects and oversee the national programme of research with a real focus on how we can draw all of that learning together. So a big part of our work is around ecosystem and health systems mapping, collating learning from across the programme. And as Joey and the team can tell you, they basically share lots of data and intel and insights from their project with us alongside all those other projects. And our role is really to bring all together that learning and share that learning with as a wider range of partners, stakeholders and players as possible. We're really interested in thinking about how we can understand the barriers and enablers to better partnership working between community assets and health partners. We know that there's fantastic work that goes on in communities, both at the grassroots level with really small scale organisations and often freelance individuals and organisations who are delivering stuff right at the coalface, at the front door, so supporting people within the community. But we also know that that ecosystem is really complicated and that there's many different types of providers and organisations out there. That makes it really difficult to understand what is available in our communities to support them. Conversely, we know that the health system and that wider care system is also really complicated. So what we're interested in is how we can bring those two ecosystems together and make them work better in partnership together. So a key part of our role is also thinking about drawing that learning together and thinking about knowledge exchange, translational activity, and stakeholder engagement. So we're really keen to work with all of our projects and all of their wider networks, along with our partners, lots of different national partners and regional partners, to think about how we can best draw that learning and share it across that wider ecosystem to bring about the kind of people-powered systems change that we know we need to make happen in order to make services and systems better for the people that need it most in the poorest areas. So we've been drawing together lots of different types of data and learning from across the projects and across this wider network of research that's going on in this area. And this is just an infographic that shows kind of how we've been doing that. And we've been using lots of quantitative and qualitative methods and more creative methods to try to draw together that learning. And I realise there's a lot of information on this slide, but I hope it just gives you some insights into how we've been bringing together some of that learning and where we're hoping to take that learning over the next few years. We're doing a lot of stakeholder mapping. We're really keen to learn from you guys. Who are the key stakeholders, players, actors within your areas do you think it's important that we influence? We've got a whole range of different types of national partners and arm's length bodies that we're working with, particularly across England and the devolved nations. And we're really keen to learn from you guys as to who you think it's important to influence. So we're really keen to learn from you about what's working well, but also what some of those challenges are and what some of those barriers are and how we can better overcome those to make that system work better. So just to end, I thought I'd just give you a summary of some of the key findings that we've been working on so far. Drawing together that learning, we've learned that we can see that there's so many community-based solutions that offer really targeted approaches to reaching those most in need. And I've talked a little bit about particularly the great grassroots work that goes on. And I know in the Choice Project, you're already working with many, many different partners who are doing brilliant work on the ground to support some of those really important communities that need support. We know that asset mapping is a really important part of this step, understanding who those providers, organisations are that are supporting those communities. But it's also really important to understand what are the strengths and gaps and understand that these offers are really relevant to the people who are living in those areas and that those individuals are involved in that decision-making process about what kinds of activities, programmes and organisations are supporting, and also what the priorities are within those communities. So we know that we need to involve local people in that decision-making process. We've also found that we really need to make it easier for decision makers, commissioners, and all those brilliant providers and organisations to tackle inequalities and identify who are the most vulnerable members of their communities and how best to target those individuals. And that's not always that easy. We know that the great grassroots knowledge that many of those organisations have is really, really vital. But that's often missed when we're thinking about commissioning and thinking about funding the kind of work that goes on in communities. We know that the kind of data and intel that, for example, population health teams have within, for example, NHS trusts or within primary care networks or within integrated care systems or the devolved equivalents, we know that the kind of data they're using is often quite different to the kind of data and intel we have from those grassroots organisations. But we've seen that by combining that intel and combining those knowledge bases, that can really help to identify how best to target the most at need and at risk communities. So it's really important, we think, to combine that intel and think about how best to combine that intel, because often those data look quite different and the knowledge bases look quite different. And again, we think that the role of people with lived experience is really, really important here and can really help bridge that gap. We've also found some great examples of co-location of services and collaborations across organisations and programmes is really the most effective way and often the most cost-effective solution to tackling inequalities. And that might be individuals and organisations collaborating together to think about services and programmes that they're offering and linking up with health partners around their priorities for communities they're targeting, but also thinking more strategically about not just the plans and the programmes that they're offering, but also thinking about the spaces that they're occupying and how they're using those spaces. So working together to offer provision in particular spaces, particularly within communities. And there's some great examples of that, and I can share some of our findings around that. And finally, I just wanted to mention about the economic evidence base, because we know that we really need more economic evidence for the cost benefits and the potential cost savings for community-based solutions to health, particularly with regards to health utilisation. So we've got some fantastic qualitative evidence that we can see real cost benefits and cost savings to the health system in a community-based approach to health. However, we do need this data and research to be much more robust, and we know it requires more investment. So part of my role leading the national programme team is also about lobbying for more research investment and more investment in understanding how we can best show the benefits of a community-based approach to health, particularly where we've got some really good economic evidence. So I hope that gives you some insights into what our role is and what we've been doing so far. I've given here some of those publications. I've mentioned some of those findings that I've gone through already, where you can find more data and evidence about that. I mentioned that we work closely with the National Centre for Creative Health, and that's a great place to start. So a year ago, they published the Creative Health Review, which draws together lots of fantastic evidence about this community's creative health approach to thinking about public health. You can see lots of examples there drawing from the Mobilising Community Assets programme, as well as loads of other case studies and examples of evidence that's particularly directed towards policymakers and providers in thinking about how we can think about this systems-based approach with a creative health lens, and how best we can make use of those fantastic arts, cultural, creative and nature-based assets within our communities to tackle health inequalities. So once again, I'm really sorry that I can't join you for your event today. I hope you have a great day, and I really look forward to meeting you during your next event, and I hope that won't be too far away. So have a fantastic day and lots of luck and all best wishes.